to all of you. First of all, let me take this opportunity to thank Team Merrill for the opportunity given. Well, over the next 10 minutes, I shall share with you on two small topics. One regarding metalless PCI, the next generation BRS, the thin strut BRS, 100 microns BRS, the Sirolimus Eluting BRS. And secondly, on the dedicated bifurcation system, the biomime branch. I'll start with biomime branch. Basically, this is how the biomime branch stent would look like. You have at the end of the stent, the most distal portion, it's for the branch. You have a smaller looking area. Then you have the flexi connectors, and then more proximally, you have closed cell design so that you can have a proper scaffolding to the vessel wall. Well, regarding the design of this technique, it's basically a diligently designed tapering balloon system, wherein you proximally have a much bigger balloon system, and distally it's a tapering system, and you also have a tough side branch portion of the stent. It's got closed cells so that you have better scaffolding of the side branch ostium. Then you have humongous flexi connector cells so that you can easily cross into the distal main vessels through these flexi connectors. And more proximally, you have a very sturdy closed cell main vessel anchoring segment also. Well, this is how the stent system would look like. Coming from most distal to the most proximal portion, you have 4 markers. Most distally, you have 1 marker here, then the second marker. The second marker from the distal most portion, it indicates the ostium of the side branch. Then you have 2 markers for the main vessel also. So one needs to be always careful with the second marker from the most distal portion. And then basically you could see here that in the most proximal portion, it's got closed cell design. In between, you have large flexi connectors so that you have a lot of space between these connectors so that it makes you easy for you to get recross into the distal main vessel once the stent is deployed into the side branch. So this is how it's deployed. Once you prepare the lesion, the stent is positioned in such a way that the second marker is right at the ostium of the side branch. It doesn't protrude into the main vessel so that whatever sturdy stent struts are there, it's primarily for the side branch, and then it scaffolds the ostium of the side branch. Then here you have the flexi connectors through which you can recross into the main vessel. So this is how the stent is positioned. Then the stent is deployed. Once the stent is deployed, you could see that these huge spaces, the huge cells are actually lying over the ostium of the distal side branch through which you can easily recross into the side branch. Then you can deploy a stent in the side branch and then recross into the side branch, and then you could have a final kissing balloon dilatation. Primarily, it's something like a modification of a culotte technique, and this is how fluoroscopically the stent system would look like. You could see that there are 4 markers. The second marker is more important. The second marker should be positioned into the side branch so that it doesn't protrude into the main vessel. Well, this is the case history of a lady who presented with an acute coronary syndrome. She had an angioplasty to the circumflex. She also had an LAD-D1 bifurcation stenosis as seen in this particular images. We prepared the lesion, the diagonal as well as the LAD was prepared, and that's the image how it looked like following preparation of the lesion. Then we did an imaging of the main vessel as well as the side branch. We made out that the vessel size of the proximal LAD was almost 3.5 plus. The daughter vessels were 2.5 and 2.75. Then we went ahead with the biomime branch stent implantation to the main vessel as well as to the diagonal. You could see the positioning of the stent in such a way that the second marker from the distal portion, it should remain inside the side branch. If it comes proximal into the main vessel, what could happen is the closed cell design would come over the ostium of the distal main vessel so that it could make us difficult to recross into the distal main vessel. So that is how the stent is deployed. Once the stent is deployed, this is how it would look like on OCT. You could see here that in the distal portion, that's the diagonal portion, you have the closed cell design, and it's very sturdy. It scaffolds the ostium of the side branch very well. Then you have the flexi connectors here. You have the large cells over here through which you can recross into the side branch, that is into the main distal vessel. And then here you could see here that there was proximal malposition. Normally you would size the stent in such a way that you have 3.5, 2.5, you have 4, 2.5, which means that the 4 millimeter diameter for the proximal vessel and then 2.5 millimeter for the side branch. So you could size it accordingly, and you could see here that the wire has gone into the side branch. The wire in the diagonal branch is clearly seen. The wire going into the distal left antidistinct artery is very clearly seen. Then you could go ahead with dilatation, then the stent implantation inside the main vessel. Following that, port, recross into the side branch, kissing balloon dilatation, report, and that would be the final result like. And OCT wise, you could achieve a good flow. Those are the OCT images, and that's a 3D image showing as the stent positioning right at the ostium of the circumflex. That's from the ostium of the LED. The circumflex ostium is clearly seen, and also distally we could see the LED D1 bifurcation also in the OCT image. That's the LED D1 bifurcation. Well, this is another example of a patient who present with effort angina, 50-year-old gentleman, LED D1 bifurcation stenosis. We prepared the lesion, and following that we positioned the branch. In the second image, you could see that the biome branch is positioned in such a way that the second marker from the distal portion is well inside the side branch. But however, what happened was during the stent deployment, somehow the stent got positioned in such a way that the second marker, it was more into the main vessel, which means that the closed cells are going to be over the ostium of the distal main vessel. However, you could see that the flow inside the vessel is good, and LAD as well as diagonal is good. It will make us difficult to recross into the distal main vessel. Now we did a part, and subsequently we recrossed into the main vessel, and once we recrossed into the main vessel, we did an OCT pullback from the side branch just to see how the struts look like. You could see here that this is the side branch, that is distal main vessel ostium. You could see that the closed cells are actually over this particular area, over the ostium, which means that the positioning of the stent was not properly done, and one should be meticulous in positioning the stent in such a way that the distal marker of the second distal marker should be well into the side branch, so that you do not have these closed struts coming over the ostium of the distal main vessel. Again, in this particular rendered view, you could see clearly that the closed cells are actually lying over the ostium of the distal main vessel, which could make us difficult to get into that vessel, and even pushing the balloon also could be difficult in these situations. Then finally we were able to dilate it, we were able to stent it, then recross into the side branch, kissing balloon dilatation was done, final part was done, and then we were able to achieve good results. So this is just to highlight the fact that this particular stent system, the stent system with a tapering balloon and a proximal huge cells that can make us easy to recross into the distal main vessel, could prevent us from closure of the side branch. And there are many advantages for this biome branch. It simplifies the procedure. It's primarily a modification of the Culotte technique. It simplifies the procedure and thereby shortens the procedure time. It could reduce the risk of contrast nephropathy because the procedure is going to be much more simpler. It could improve the procedure success rate, allows permanent side branch access because the side branch ostium is covered only by very few struts, and final optimal stent expansion and side branch ostial coverage could be achieved. Well, coming to the new generation BRS, the MIRRS by Merrill. Basically, why do we want to have a second generation BRS? We know from the ABSORB 4, the four-year outcomes of the ABSORB trial, that as time goes by, you tend to have more and more of events. So how can you reduce the events with the newer generation of bioresorbable scaffold? Primarily try to improve the device. That is, you could have thinner struts. ABSORB had 150 micron struts. Here we have with MIRRS, it's 100 micron struts, and you have mechanical properties of the device is much better compared to ABSORB. And then the technique of implantation also, one should be meticulous. Probably one needs to pre-dilate, do imaging, post-dilatation. All those things should be given a lot of importance, and a prolonged DAPT could fetch you better outcomes in the long term. Now, what way is MIRRS different from ABSORB? Most important thing, it's a Sirolimus Eluting system and 100 microns, and you could see that it's a hybrid cell design. In the most proximal portion, you could see that it's a closed cell, and in the mid portion, it's an open cell. So in the most proximal as well as distal portion, you have the closed cell, which provides you a good radial strength, and in the mid portion, you have open cells, so that you could have a better access to the side branches. Well, you also have a better radio-opaque, triaxial radio-opaque markers, so that you can very clearly see the positioning of the stent compared to the first generation BRS, wherein it was difficult for us to identify where the markers are. Well, again, this is how it would look like compared to ABSORB. You could see that it's 100 microns compared to 150 microns. The initial first generation used to be a more boxy one, and this is how the radiopaque markers would look like compared to the upserve. You could see that there are 3 radiopaque markers. The triaxial radiopaque markers are very clearly seen, so that you wouldn't miss it actually also. Now this is an example of a case, a patient who presented with an anti-wall myocardial infarction who was thrombolized and then taken up for an angiogram. He had an OM lesion which was stented with a biomime stent, and then we looked at the proximal left-handed descending artery, which was a culprit anti-wall myocardial infarction. You could see here that there is a small ectatic segment beyond the tight stenosis in the left anterior descending artery. We did an OCT evaluation. The proximal vessel was 4.2 millimeter. The distal vessel was 3.9 millimeter, and the ectatic segment is almost 6 millimeters. So we wanted to use a mirrors in this particular situation, so that even if it overhangs into the ectatic segment, probably over a period of time, it will disappear over a period of time. So we decided to use a 3.5 millimeter mirrors and post dilate with a 4 mm balloon. So that is how it was done. We could see that the mirrors is being pushed into the coronary artery. You can see the markers very clearly. The stent was positioned in such a way that the marker is right at the ostium. Proximal to the markers, you have just 1.2 millimeter of the scaffold protruding into the main vessel. Then it is deployed at 14 atmospheres. It was post dilated, and those are the post dilatation. And then you could see that the repeat OCT evaluation shows us that the strut is around 110 microns, and you could also see that despite doing post dilatation with a 4 millimeter balloon, there was some proximal malapposition near the ostium, which was further dilated with 4.5 millimeter balloon in a 3.5 scaffold, and finally we were able to achieve good results. Those are the final bifurcation image showing us that it is well opposed, and angiographically the results were looking reasonably good. So regarding take-home message, dear friends, imaging while using a BRS, it's always imperative that we use imaging so that we tend to see the vessel architecture. The vessel can be well prepared with cutting balloon or scoring balloon. If it's a fibrotic lesion, we could size the vessel very clearly. Proper pre-dilatation is a must. Tracking the scaffold is not difficult in many of the lesions. Positioning, one should make sure that while positioning it at the ostium, one should keep in mind that proximal to the radiopaque marker 1.2 millimeter, the scaffold protrudes into the main vessel. Do not undersize, because once you undersize, what could happen is it's little bit boxy, 100 microns, so that the next balloon might hit at the side of it, and you might find it difficult to push it into the vessel. High pressure post dilatation is always preferable. Post dilatation probably should be 0.75 millimeter more than the size of the scaffold that we use. In a 3.5 scaffold, you could go up to 4.25. We have gone up to 4.5 without no much of damage to the scaffold. And post-procedure imaging is always preferable, since we need to have a perfect result. We shouldn't have a mishap similar to what we had with the first generation stent. Thank you so much.